practice, which brings together people working in cancer care, researchers, clinicians, advocates, administrators, ministers of health, policymakers, and most importantly, patients and their caregivers and families. So we meet regularly every month. We choose a topic related to cancer control, and we discuss that. And we do have speakers from the community who come and present cases, but also give us more didactical presentations. And that is the same setup that we have today as well. We ask you to mute your mics so that we don't have a lot of disturbances from around where you are. So please put yourself on mute. But as I mentioned, please keep your video on if the bandwidth allows, and then we could have the session go without interruptions. You should also know that we provide certificates for those who have attended. So log in with your details so that you can get the certificate, and the proper name can be put the certificates. This, for example, you can use if you want to share with your boss. Let's say if you're at a hospital and it shows that you've been attending these sessions. And for some people, they can use that as continuous professional development. So please indicate your details when you're logging in, and then we can use that for the certificates. So use the chat, ask questions. There will be a session for Q&A, but of course you can use the chat to ask the questions as the speakers are presenting, and we'll try to attend to them. Because if you wait till the end, you might forget the questions, and we don't want you to go out with the questions because we have experts today. You can enable subtitles on your screen as needed if you need a bit of assistance with listening. And please remember that the sessions are recorded. I think now it has already indicated they have started to be recorded. If you don't want to appear, please tell us. But we hope that you are okay with the recordings, because we keep them on YouTube so that people who are not able to join can find them later, and also yourselves can go to listen to them later. So that is a bit of the housekeeping that we needed. Today, we're discussing cancer registration systems in Africa, and especially the role of the Africa Cancer Registry Network, which is being represented today. We'll look at the challenges of cancer registration, the importance of cancer registries, and how they contribute to cancer control. And of course, me as a person who works in digitalization, I'm also interested in how we can use digital solutions to improve the registration. So that's the housekeeping. And right now, I introduce you the speakers. We have Dr. Judith Mwanza. So I already talked about myself, so I'll not, continue with that. But we do have two speakers, Dr. Judith Mwanza and Dr. Eric Choknonga. So Mr. Eric Choknonga currently serves as the head of the Zimbabwean National Cancer Registry, a position he has held since 1989, and has extensive training in cancer registration and surveillance. And he has been a consultant on cancer registration and surveillance with IAC and WHO and UICC and the Africa Cancer Registry Network. So we are really in hands of an expert, and he will discuss a case. And then the second speaker is Dr. Judith, who is a medical doctor and has a PhD in public health, master's in epidemiology, and PhD in HIV management, and works at the South Africa National Cancer Registry and oversees surveillance and research and advocacy activities there. We can, of course, share these details as well if you want, and the contact information of the speakers. But we are very honored that you're here today. Charles, are we starting with Eric? Start with a case? Can you advise that?
Yeah, I think we can start with Eric.
Right. Okay, so over to you, Eric. Tell us about Cancer Registration Network and whatever you prepared for us. I think, do you prefer to have control over your slides so that Charles stops sharing, and then you will Um, you share your presentation. Yeah. If not, I can also put the presentation on. I just want to check that we can hear you because I see you speak, but I don't hear you.
Can you hear me?
Ah, yes, perfect. I hear you.
Okay, great. Yeah. All right. So let me try to see if I can share.
Yes, your presentation is coming through.
Okay.
There we go. We see it.
Okay. So can we see it? Is it
Yes.
visible to all of us?
Yes.
Yes. Good afternoon, everyone, wherever you are. My name is Eric Chokunonga. I'm the head of the Zimbabwe National Cancer Registry. So it is my pleasure to present this important, session on cancer registration in Africa. So in this presentation, I'll be sharing with you the Zimbabwean experience. So Zimbabwe is located in Southern Africa. I'm sure most of us are already familiar. To the north, we have Zambia. To the north of us, to the east, we have Mozambique. To the south, we have the Republic of South Africa. And to the west, we have got Botswana. So in Zimbabwe, cancer registration and surveillance is the responsibility of the Zimbabwe National Cancer Registry. And the Zimbabwe National Cancer Registry is part of the Ministry of Health and Child Care. And the Zimbabwe National Cancer Registry has evolved over the years to become arguably the leading population-based cancer registry in sub-Saharan Africa. The Zimbabwe National Cancer Registry was established in 1985, and it's now 40 years old, and making it one of the oldest cancer registries in sub-Saharan Africa. At inception, the registry targeted the population of the capital city of Harare, and complete coverage was achieved in 1990. After achieving complete coverage, we decided to reactivate the Bulawayo Cancer Registry, which was the first cancer registry in Zimbabwe. So the Bulawayo Cancer Registry was reactivated in 2012 after the Harare Registry had achieved complete coverage. So Bulawayo Registry achieved complete coverage in 2021. Now, the Zimbabwe National Cancer Registry is targeting the entire national population. The population is about 15 million people. So we are now a national cancer registry attempting to cover the entire, a national population. At present, we estimate that our coverage is more than 85% of current coverage. So the registry is located at a perennial group of hospitals. This is the largest referral center in Zimbabwe and is located in the capital city. And it serves mainly the northern part of the country. And there are two major cities in the country, so Harare and Bulawayo. So the National Cancer Registry is located at Paranyato hospitals. Its activities are overseen by a 17-member constituted multidisciplinary advisory committee. The registry is a staff establishment of 4. That's 5 staff in Harare and the other 3 in Bulawayo. So this is a perennial group of hospital. The main entrance and the cancer registry is located a few meters from the main entrance of the hospital. So this is the advisory committee of the cancer registry, the Zimbabwe National Cancer Registry. Like what I said, it's multidisciplinary, and it has got a constitution. So it consists of specialists in various disciplines. We have oncologists, we have pathologists, gynecologists, pediatricians, and so forth. So this is the staff of the cancer registry during the AIDS pandemic, during the COVID pandemic. So let's move on to case finding. Cancer is not a notifiable disease in Zimbabwe, so there's no legislation governing, cancer registration and surveillance in Zimbabwe. So the registry uses a combination of active and passive methods of case finding, meaning that cancer registry staff visit facilities in the healthcare delivery system of Harare and Bulawayo in order to register cancer patients. We also receive notifications directly from some of the facilities. So some of the facilities have got cancer notification forms that we leave with them, and they complete the notification forms for the patients they see. So cancer diagnostic and treatment facilities around Bulawayo are visited routinely to register cases. And the regional hospitals, these are the provincial hospitals, the district hospitals, and the mission hospitals, notify the cancer registry directly by filling in the cancer notification forms. Right, I think I move on to this one. The sources of information. So these are the major sources of information of the registry. So government hospitals, all the government hospitals in the country, the central hospitals, the provincial hospitals, the district and rural hospitals are important sources of information for the registry. Then we also have access to private hospitals and clinics. And then municipal hospitals are also an important source of information for the registry, and as well as public and private pathology labs. So we either receive copies of histology reports from some or certain private labs, in the public laboratories. Sometimes with the other labs, we receive their databases of electronic databases of cancer cases. We also get data from radiotherapy and oncology centers. So in Zimbabwe, we've got two radiotherapy and oncology centers, public radiotherapy and oncology centers. One is in Harare and the other one is in Bulawayo. And we have one private radiotherapy center, which is located in Harare. We also visit the death registration centers in Harare and Bulawayo to, collect data from death certificates. Hospices and cancer centers are also sources of information. And we also get data from private voluntary organizations that are involved in cancer work. So for data processing, we use for coding, we use the ICDO version 3 coding system. For data processing, data entry and analysis, we use the CANREG software, the version 5 of CANREG software. So we do have a rigorous record linkage procedures for avoiding a duplication. So it is also important to note that the Zimbabwe National Cancer Registry is the primary source of cancer data in Zimbabwe. So the data from the registry are used by our Ministry of Health and Child Care for cancer prevention and control programs. The data are also used by indigenous and international researchers. And materials, they're also used for materials for lecturers and students, materials for conference participants, and also provides materials for health educators. So this is our outgoing national cancer prevention and control strategy. So we now have a new one, which was unveiled last month. So data used in the national cancer control strategies and plans are from the National Cancer Registry. So we are very happy that our data are used by the Ministry of Health for cancer prevention and control strategies. So in terms of achievements, these are our major achievements. Our achievements are too numerous to document, but I have just highlighted the major ones. So we have contributed data to 6 successive volumes of the Cancer Incidence in 5 Continents series. So we started contributing in a volume 7 for the period, I think that was 1990 up to 1993. So we have contributed data in 6 consecutive, CI5 series. That is from volume 7 to volume 12. So we are presently working hard, cleaning up our data for submission to the upcoming volume 13 of Cancer Incidence in 5 Continents. So the registry also provides data to the IAC for the GloboCan project. The GloboCan project, of course, produces periodic estimates on cancer worldwide. The registry has voting membership in the International Association of Cancer Registries and the Union for International Cancer Control, and we are an active participant in the African Cancer Registry Network. We have published more than 60 papers in peer-reviewed journals. So as you can see, the Zimbabwe registry, Zimbabwe is one of the few registries on the African continent that are considered to be producing high quality data. So those in blue are the countries worldwide that are producing high quality data. And we are very pleased that we are one of them. We are in the category of the United States, Australia and all these other countries, together with our sister registries in South Africa, in Kenya, in Uganda. I think the other one is Tunisia, and so forth. Right, so this is a cancer incidence in 5 continents, volume 12, which was published in 2023. We are one of the countries to have contributions from 2 population-based cancer registries. So down there we have got Zimbabwe, Harare African, and then we have Zimbabwe Bulawayo, together with the registries in Uganda, South Africa, Seychelles, Mauritius, Kenya, Reunion, and Benin. And as you can see, very few cancer registries in Africa are doing very well, and we are happy to be among these. So the strengths of the Zimbabwe Cancer Registry, I think we derived our strength from government support. So all the full-time staff of the registries, of the Zimbabwe National Cancer Registry, are government workers. So the staff are full-time and they are paid by government. They enjoy all the benefits of government workers. And because we are located at a central hospital, a government central hospital, the government provides a free accommodation. We do not pay electricity, water, and other utilities. And the other strength of our registry is that we have a functional advisory committee. This advisory committee provides guidance to the registry and also does, a fundraising for the registry. So I think the registry derives its, strength from the these two main these two organs: government support and the functional advisory committee. So we also have a total support commitment from the public and private institutions. These are our data sources. So this is very critical in the absence of legislation on cancer registration and surveillance. Like what I said, cancer is not a notifiable disease in the country. So we rely on voluntary reporting from the public sector. I know some of our sister registries have challenges in getting data from the private sector. We are very happy in Zimbabwe that we have a good working relationship with the private sector, so getting data is not a problem. So we also have a dedicated staff. Our staff are very dedicated, and we also have a very dedicated medical director. So the challenges, our weaknesses are that the absence of legislation governing cancer registration and surveillance. So the cancer registry is currently lobbying for cancer to be a notifiable or reportable disease. This is important, especially in the future. And we publish annual reports every year. So since 1990, we've been publishing annual reports every year. So we like what I said earlier on, we have published lots of we have lots of publications in peer-reviewed journals, and of course we have contributed to 6 consecutive volumes of cancer incidents in 5 continents. We have also contributed data to volumes of the international incidence of childhood cancer, cancer in Africa, and other publications by the African Cancer Registry Network. As I said, the registry has evolved over the years to become a leading registry in the region. So we provide a capacity building to registries in the region. So there is the ZNCRI has been providing technical support to registries in the region on behalf of the IAC, the IAEA, UICC, and the African Cancer Registry Network. We have hosted trainees from sister registries in the region, and we facilitated training courses on cancer registration. Yeah, okay. These are a few examples. I facilitated a training course in Eldoret in Kenya. I think that was in 2019. So people also visit us. I think you can see Tolisile Dlamini from Swaziland. They visited the registry. And I also participate in a IAEA impact missions. So this was an impact mission in Seychelles. So what are the challenges? Our major challenges are financial. Although we are part of government, we do not have a budget line within the MOH, within the ministry structure. So what the ministry does is that it pays the salaries, provides accommodation, and as I said earlier on, but we do not have a budget line in the structure. So this is currently being looked into. So the advisory committee is expected to raise funds for operating costs. So this is really challenging because it's increasingly becoming difficult because partners are also resource constrained. So this is a major challenge for financial, and we also have staffing challenges. Staff retention is difficult because of the low salaries in government, and when staff leave the registry, it's very difficult to get replacements. So staffing is a challenge. What are the future plans? So we now have a new national cancer control plan for the period 2025 and 2030. So in the plan, it is planned to capacitate the ZNCR in order to enable it to achieve complete national coverage. So our aim now is to able to achieve a complete national coverage so that we account for all the cancers that that occur in the country. So like what I said earlier on, we estimate our current coverage at 85%. So we want to account for the remaining 15%. So that's our future targets. And we are also exploring use of the DHIS tool. So we are currently piloting the oncology module of the DHIS2 program through facilities in the country. So this is our current annual report. Like what I said, we publish annual reports every year. So this one is the current report. So I think I end there. So I would like to acknowledge the support of our partners, our government Ministry of Health, the African Cancer Registry Network, Vital Strategies, Bloomberg Philanthropies, and the International Association of Cancer Registries, as well as the Union for International Cancer Control. Thank you.
Excellent. Thank you so much, Eric. And you are right on time, so very much appreciated. This is very insightful and a very good job done, having quite a high coverage and having this very good data that clearly is very useful, being contributing to data sets that are used for planning. So really, thank you so much for sharing the insights from your registry. We can allow people to ask a burning question, one or two, before Judith starts. So please, if you have a very immediate question that you want to ask Eric, you can type it in the chat. You can also raise your hand, and then I can give you a turn to ask. Is there a burning question before we go to Judith? Should I ask as the moderator? I always get to ask all the questions that I have, so I could also do that. Yeah, Eric. So I have a question about the use of the data. You mentioned that it has been used to inform the national cancer strategy. But I want to get some concrete example. Has there been, for example, a change in the budget to cancer control in the country that is because of data that is coming from here, or has the government decided to, buy a second radiation machine because they are seeing increases in the data in the cancers that require radiotherapy? Or give me some examples of this. How has this been practically used for decision making?
Okay, thank you very much for this important question. Yes, like what I said, the registry is the primary source of information on cancer in the country. So planning for cancer treatment equipment, the registry is based on the data that are produced by the registry. So the numbers are going up. So the ministry will know which cancers to target. So quite right, drug procurement. So all this data, all this information are informed by the statistics generated by the cancer registry. So indeed, cancer programming is also based on the statistics that are generated by the cancer registry. Thank you.
Thank you. That's very encouraging. I have not seen any questions in the chat, so I can ask my last question and we'll move to Judith before Eric. I think he will be in the he will be available online and he will be in the answering questions in the chat. So please put them there as well. The last thing that I want to ask you, Eric, is if you can give some details on what you mentioned on the issue about identity of patients. You said you have a very robust record linkage mechanism to make sure that cases are not duplicated. This is, for me, a very important issue. People move between places. If you don't have a national identity number or some kind of social security number, then you get the same case reported at the laboratory and then also reported at the hospital and in this death register, but you don't know if it is the same person. Could you just mention a little bit of, explain a little bit on how you actually solve this problem?
Okay, thank you. Firstly, as you may know, the Connect software that we are using, Connect 5, has got inbuilt, record linkage, facilities in it. So it's possible you can do before you add a cases to the database. You have to check first in the database whether this case is already in, and periodically we do a batch duplicate searches so that we are able to avoid duplication. And we also have the manual systems, like periodically generate printouts so that staff physically check through those printouts, identifying possible duplicates using names, ID numbers, and so forth. So it's both in CanReg as well as manual.
Thank you
Thank
so
you.
much. And thanks a lot for sharing your insights. Again, if you have questions, please put them in the chat. I think for me, this is a very interesting topic and there should be lots of engagement. Now we go to Judith to give us the didactical presentation. And I see that your slides have come through. Please take it away, Judith.
Thank you. Can you hear me?
Yes, I can hear you. I hope everyone else hears you well. Yes.
All right. And I'll just put that in presentation mode. And are you seeing it in presentation mode?
Not yet. Oh, now it is.
All right. All right. Thank you so much for this opportunity to present in this forum. And if it's okay with you, my internet is a little bit shaky, so I will switch off my video for the duration of the presentation, but I'll turn it on as soon as I'm done, if it's okay.
That's all right.
Right.
Thank you. We can then focus on what you're speaking.
Yes, thank you. So I tried to coin the overall title for today's presentation as Cancer Registration in Africa, but it does cover a couple of things, as you will see. And as indicated, I am from the South African National Cancer Registry. And why are my slides not moving? Just a second. Okay. So before we get started, there are just a couple of things that I would want people to think about. I want people to be able to, like if you're asked to explain, and just as a reminder, perhaps maybe some people may be joining for the first time and they'll be wondering what cancer registration is. So that's why I've put it there. So if you're asked what 3 words come to your head, these are just things I want you to think about, but we'll get into your voting just now. What do we know about cancer registration in Africa? Apart from what Eric has shared with us, what do we know about cancer coordination in Africa? So with those 3 questions, as you're thinking about them, I'm just going to stop sharing and share the Mentimeter. Before I share the Mentimeter, I would want people to scan the QR code. I hope everyone has a phone, but maybe let me also just paste.
Yes.
Let me paste the link. Yes, let me put the link in the chat. I'm doing that just now. Whilst others can be scanning, those that are able to scan.
So you can get your phone and get a QR code scanner so that we can hear from you. We want you to be engaged and not bored. So please scan and join this page, Mentimeter. We will not ask for personal information or your credit card number, so don't worry. We want you to pass.
True. Okay. So I'll just
And it's
switch the
also in the
screen.
chat. If you don't have a QR code scanner on your phone, you can just click on it in the chat.
Thank you for that. Yeah. So, and then I'll just share the screen for the Mentimeter. On the Mentimeter, you would have been taken to a question, which I will just show. Oh, are people already answering? Okay. I just want to share the screen.
I hope no one failed the first question, yeah? Because then we will not let you stay on the mother continent.
Are people failing the questions? That would be disappointing. Okay, I'm giving it a few more seconds. I'm not sure what screen you're seeing now.
Yeah, the Menti one has come through.
Okay. Okay, I think we can move to the next question, right?
Yeah. There's a few people who gave different answers for the first one, but you are the examiner.
Yes. No, it's fine. These are things that we need to think around. So how many countries are in Africa right now? We're not going to say the answers at this point. I just want people to have this perspective as we get into the presentation, and they'll mark themselves as we go along.
Yes.
But we can discuss at the end. So this is the next question. I think people are on the next question. So it's how many countries are in sub-Saharan Africa? We're giving that a few seconds as well before we move on. I think we can move to the next question.
We have 28, yeah, 42 responses. There's also people who have not joined. We have about 80 people and only half are joining the Menti.
Okay.
Please take in the link in the chat so that you can all participate in the democracy we are having. Yes.
I hope it's not because they're thinking the questions are too simple.
Yes. Yes, we
I-
can proceed. I think you have fairly good response.
Okay. So when you think of cancer in Africa, what one word comes to your mind? Just one. Death, disaster, rare, disease, burden, disaster, okay. AFCRN, breast, kills, poverty, expensive, right? Pain, a lot, prostate. Wow. Underfunded. Okay. It's overlooked. Leukemia. So the big ones are death, burden, expensive, increasing. Yeah. All right. Medication costs, scary, toxicity. Okay. So death, burden, pain, increasing, expensive seem to be dominating, and poverty.
And
Okay, now,
data is only showing up very slightly there. So
yeah,
in relation to today's session,
yes. Okay, I think I have two more. Can I move on to the next one?
yes.
If asked to explain what cancer registration is, what three words would you use? Okay, count, oncology data, cancer data. Okay. Team effort, that's good. Analysis, system, storage, cancer mortality, statistics. Okay. Okay. All right. Oh, there's still. Okay, thank you. I'll move on to the next question. What are the types of cancer registries that you know of? You can just put one, or if you know two types, you can put them there. So there are five. Okay, someone knows national, hospital-based, cervical, breast, prostate, special registries, pathology. Okay. Right. Not to cut you short, I'm going to move to I think it's the last one. Okay, so we see what's coming out there. It's the population-based, the hospital-based, pathology-based, special registries. So this sort of like encompasses all. The special registry, yeah, okay. So the special registries would be for specific cancers. Yeah, and I think this is the final one. Rank the following cancer registries according to importance, according to what you view as important.
And this one is for drugging. I see, yeah, many people have already figured it out. Drug and put in order.
Okay, yeah. Okay. Okay, I think we're done. So we see that population-based cancer registry is number one for most people, and hospital-based, then pathology and special registry seem to be switching. And the pediatric cancer registry is the least important. Okay, it's a poll. Thank you. All right. Okay, so thank you, everyone. I think we can move back to the PowerPoint. If you want to view your results, you can actually view them on the Mentimeter. I think it gives that option. Okay. Are you seeing the correct, the presenter mode? No?
Presenter mode, so you can switch to
I can switch. Is that
yes,
okay?
there
All
it
right.
looks good.
Okay. Okay, so I won't even get into the details of what the outline of this presentation is because I think it's been given. I'll just get into it. And there's an overlap of some of the slides, I think, with Eric's, but that's okay. I think we cannot talk about cancer registration without talking about the burden of cancer. And this is from GlobalCan, the latest, the 2022 report, just showing us what the cancer incidence rates are. And this is for both males and females. And the darker the blue, you will see that then the incidence is high. But then what's striking for this slide is the fact that the very pale color shows no data. And we see that in Africa, we do have some places where there's just no data available. So that is very important to take note of. And why is that important? Why do we have to talk about cancer? Because cancer has a significantly increasing impact on the economic status of individuals and countries. And as of 2010, the economic cost was over $1 trillion US. In terms of data, which is what we're interested in when you speak about today's talk, it's not optimal. We have 1 in 5 from low and middle income countries that actually have the necessary data that we would need. Why do we need this data? Why do we need data from the cancer registries? We need it because it's supposed to inform policy. You cannot have policies without knowing what the actual problem is. And this one is showing the data, and as in the fact that there's a huge gap in sub-Saharan Africa. I think this slide was shown with my colleague, but just to point out, so the darker the blue shows that there's high quality data from the population-based cancer registries. And he did mention that Zimbabwe is one of them, but it's interesting to see that when you look at Africa, there's very few of the dark blue. So yes, we're making strides, but we still have some more strides to make. Okay. This slide is just showing the fact that it's the coverage of the cancer registration by African regions. And on your y-axis, it's the number of countries. So you see that in each region, this is varying. And the red is showing how many of those countries are actually AFCRN members. Ideally, it would be nice to have the orange and the red at the same level, but it would also be good to have regions like Central Africa to be elevated, those numbers to be elevated, to be at the point of where East Africa is reaching. Okay. What progress has been made? From Eric's presentation, we do see that there's been great progress. And when we look at Africa overall, we see that mandatory reporting of confirmed cancer cases is there in some countries. In some countries, it's not there. Eric pointed out that it's not there in Zimbabwe, but they've found ways to go around this, and they're still working towards making it mandatory, making the reporting mandatory. For example, in South Africa, it's been mandatory since 2011, when there was a regulation that was passed that all cancer cases should be reported. And speaking to that, cancer because it's a reportable disease or a condition, we've tried to see how it can be done, and I'll show you how in one of the next few slides. So cancer registration can be both active and passive, as Eric has mentioned. So the active is where you go and you're looking for the cases. The passive, in our case, like in South Africa, this is through a data dump, where you the data from the private laboratories comes through to the National Cancer Registry. But we also have the population-based, which is mostly, when you speak of pathology-based registries, it's through laboratory reporting, and that is where you make that arrangement that the data flow goes to where it's supposed to go. The active is the one where you go out and you're looking for the cases. You look for the cases in the mortuaries, in the different places of the hospitals, or even home visits to go and find out what's happening. That is active case finding. CanReg 5 software has been used, as Eric mentioned, and it has good features that enable the linkage, as he's mentioned. But also REDCap is another software that's being used, like in South Africa, because there was a problem with the CanReg in terms of, I think it had to do with the number of cases. So it kept crashing, and as an interim, we started using REDCap for now. So in terms of linkage, we've had other ways that we're doing the linkage, but we've also needed to do the linkage because we don't have everything in one place. When we speak about the pathology-based registry, we don't have the mortality data in there, and we would need to link to mortality. Training in cancer data management and data harmonization through record linkage. That is something that is ongoing. For example, South Africa serves as a center of expertise along with two other centers in Africa. Our duty is actually to train on record linkage, and we are particularly doing this for cervical cancer. So we're trying to link the screening data and the cervical cancer diagnosis. At the moment, we're also trying to get the HPV vaccination information or the data on HPV vaccination so that we can have all those data sets linked. We're using deterministic record linkage, but we also use the probabilistic. So probabilistic is more where you're literally trying to see how probable is it that this person is the same person in here. That's because maybe you have the same surname and same first name, but the date of birth, there's an error somewhere. So that has to do with probabilistic linkage. So some countries have done very well where establishing population-based cancer registry is concerned. I think like Nigeria has over 20 of them in the country. In terms of challenges, underreporting, yes, I think for Eric, Zimbabwe doesn't have that problem with the private sector. Other countries have that problem where the private sector does not send through their reports. Funding for the population-based cancer registries, I know in South Africa, it's not funded. I don't know, and I think other places in Africa. So the funding is dependent on, like NGOs, if possible, or maybe like operational budget of an institution to do the surveillance. There's limited public awareness. I think the public needs to be made more aware of the existence of cancer registration and the importance of it. This can be through campaigns, advocacy. For South Africa, when Section 3 that mandates everyone to report cancer registration was passed, part of it was that advocacy should be put top on the agenda as well. It helps patients and caregivers or just the relatives to understand the journey of a cancer patient. In South Africa, just to mention on the public awareness, there's actually an NGO that has been started. It's called Living with Cancer. So the Living with Cancer is for patients. It's a patient-led registry. So patients can go onto the platform and they can register their cancers there. Then they can also just upload their histology report. As the National Cancer Registry, we have an MOU with them so that the data that they collect can come through to us. We're using that to correct our data that we have already, so that we can correct it in case there's some cancers that we're missing. Capacity building is still required. Eric mentioned that, but it's not unique to Zimbabwe. Cancer information officers, surveillance officers need to be trained on how to use everything about cancer registration. Limited national coverage. So in places, in developed countries, population-based cancer registration is the gold, it's the norm. And for them, it's national. in Africa, because of funding problems, it's not that easy to have a national population-based cancer registry. So we have the sentinel ones in different parts of a country. So in some places, you might find that these sentinel places are only in the urban areas, and then the rural areas are deprived. The gaps in data quality and system integration, that, as you know, data quality is something that is always a problem in terms of how we are collecting it. And that's why we have to look at other ways of collecting this data, because you can have small errors that can actually be life-changing. Maybe if we have a digital way of doing it with drop-down menus, that is one way to go, so that people do not misspell names, etc. Cancer coordination in Africa. So we have the Africa CDC, they have the regional coordination centers, and they have their headquarters or their main hubs in 5 countries. This enhances collaboration, but we also have the centers of expertise. Like I mentioned, South Africa is one of them, but we have Kenya and Ivory Coast. This is in partnership with the AFCRN and IAC. In terms of research and capacity building, that is also happening across Africa. And one example is the introduction of the Big Cat, which is the beginning investigator grant for catalytic research. This is for early career researchers. Like, you apply for a grant so that you can actually conduct research to improve the state of your cancer registry, or you conduct research that would also help in other ways, but everything to do with cancer. A little bit about the AFCRN, which is the Africa Cancer Registry Network. So it's a consortium of population-based cancer registries, and it provides activities of a regional hub when you speak about registration, cancer registration. And you see that it's in sub-Saharan Africa. So that had to do with the WHO regions that was followed when this selection was done. And currently, as of April 2025, there are 37 registries, member registries, and these are in 25 countries. Like I mentioned, you can have more than one registry in one country. So the membership to this consortium is by invitation, and you can also be recommended. So after you're invited, after there's a visit by a consultant from the AFCRN, then you are invited to be a member. And the consultant can come through maybe after you've been recommended by 2 existing member countries or members in the AFCRN. And your registry has to be a population-based registry, and you need to be covering at least 50% of the target population. You also need to have an active, up-to-date website, and you should be attending the meetings that are held. There's been successes in the AFCRN, a lot of successes. The AFCRN has been in existence since 2012, and it has made great strides. As Eric had mentioned, with all the publications, that is all part of the success of the AFCRN, knowing that Zimbabwe is part of the AFCRN. The AFCRN provides technical and scientific support, and it is involved in training just to ensure that the population-based cancer registration is optimal and that the data is being used for what it should be used for. It also conducts research, international research on the projects, and these findings are disseminated at conferences or various fora, including publications. Advocating the cause of cancer registration in the region, the AFCRN is very strong on that. So generally, the mandate of the AFCRN is cancer surveillance. These are some of the successes in terms of publications. Okay. So we can move on to digitization. What is digitization? So it's conversion of paper-based medical records into a digital format. Okay. It comprises electronic health records, electronic medical records, and digital health information system. One may ask what the difference between the first two are. The medical records are usually like for a particular facility. And for me as a patient, my records at that facility. Then the electronic health records, it's me as a patient across different facilities so that you can actually tell where I've been. You can pick up, if I was in that district of the country, you can still pick up and see what my medical history is, and you'll be able to treat me accordingly. Then the digital health information system is where you have like the DHIS, district health information system. Yeah, the DHIS 2. In South Africa, we also have, like in the Western Cape province, they have a patient health information system as well, which is specific to the province. The advantages, so it's when you have, if you digitize the records, like for cancer or just generally, these will be structured and they'll be standardized because you just have drop down. Like I mentioned earlier, you will avoid people, the spelling mistakes can be avoided. And then data is available in real time. It's also easy to follow up patients because you can put reminders, like if this patient was here at this facility today, we know that we should see this patient in the next 4 weeks, so there can be a reminder on the system. The storage is also secure. It's password protected, but you can also have backup. It's on a server. It's not just available on one machine. And it's easy to share the data than moving around with piles and piles of paper in boxes from one place to the next. And I think I have spoken about the benefits already, unless people have other benefits of what they think are the benefits. And what do you think the role is in cancer registration? Do we have time for this or should we just skip? There are two questions. It's the two questions I put up. Yeah.
We scheduled to go until half past the hour, so we want to. I think let's go through with it. Let's see if yes, we can have the Menti interaction.
Okay, so people can just scan that. In the meantime, I will also try to paste the link to this one in the chat.
And while you do that, someone has asked if the slides will be shared. I hope that the speakers don't mind the slides being shared, but we don't want to email everyone because some people might not be interested in them. So if you need, you can send using the link used to register, you can request, and the slides will be given to you. I also want to remind you that the recordings are always uploaded on YouTube, so you can play back this discussion, which of course includes the slides as well. And I'll put the link to the YouTube channel there in the chat. Otherwise, you can go to YouTube and search for Africa Cancer Echo. You subscribe, you'll get new recordings, but you'll find all the recordings that we have had since the ECHO began. So we've been running for many years, and you can find different topics. I think now everyone has Menti loaded, and they can start answering.
Okay. I'll just project what the results are. Give me a second. Okay. Oh, I see people have started doing answering already. Let me just project that screen.
And Sam has also advised that if you are on iEcho platform, you will be able to get the slides there. That is the platform that you used when you're registering.
Oh, okay. I don't know what screen you're seeing.
Yeah, the results of Menti have come through.
Okay. But it's not in present mode, but I guess it's fine because they're just 2 questions. So we can do that quickly. So what one word comes to your mind when you hear digitization? Okay, it's electronic, it's efficient, okay. Interoperability, no lost records, okay. Computers. This is interesting. Okay. It's not changing much, so I can move to the last one.
Yeah.
Given the status quo, can cancer registration in Africa be digitized? Are people able to, or maybe it's not moving to the next?
Mm,
Because I
maybe
don't
need
know.
to refresh.
It's actually asking me, it's not giving me the option to present. That's what I've seen as a
Yeah.
challenge. Does it do what? Oh, I'm on a different screen. Apologies.
Probably, yeah, something is broken.
Probably. Let me stop sharing. I if it does come through, I don't want to waste.
Yeah. But I see that a lot of people are saying yes in the chat.
Oh yes, we can use the chat. We can use the chat actually.
Yeah.
It will be quicker because it says the options are yes, no, maybe. So people can just say that. Okay. Okay, having said that, I think now we can finish off the few slides left for the presentation.
And please, again, remember to put questions in the chat so that they can be addressed both to Judith and also to Eric, who presented the case before. Yes, your slides are back, but now they are there. We can proceed.
All right, thank you. So I wanted to give an example of when we talk about digitization, I just wanted to give an example of what happens here at the National Cancer Registry in South Africa. And I'm not giving the case study of our registry, but I'm just trying to highlight in terms of digitization. So we have 3 registries. We have the pathology-based registry, which is the oldest, started in 1986. And this is purely lab confirmed cases. So there's no clinical diagnosis, there's no radiological diagnosis. That's the one on your top left. Then bottom left, we have the population-based registry. We have 2 of them at the moment. And I would say 2 plus 1, making the third one the Eastern Cape Cancer Registry, which has been there longer. It's been there since 1995. So and then the second one was the Ekurhuleni, which is a district in Gauteng province. It's been there from 2017, and then eThekwini in Zululand in KZN. The Childhood Cancer Registry is fairly young, from 2019. I just wanted to point those out as I talk about the records and how we handle the data. So we get the data. So the National Cancer Registry is part of the National Health Laboratory Service. This is a network of laboratories across the country, more than 200 public sector labs. So we get the data from there. We also get data from the private labs. We also have the patient care management systems. These are what we call SIOC, which is South African Oncology Consortium. There's also Icon Oncology. These are they manage the private sector, so they have the data. Then we have Living with Cancer, which I had mentioned earlier, the patient-led registry, where patients self-report. The NMC reporting. So NMC is notifiable medical condition. In as much as, so we have, this is the NICD, and we are part of the NICD. Notifiable medical conditions. Cancer is not a notifiable medical condition, but it's a reportable disease or condition. So we've been lobbying, and work is underway in terms of having the cancers reported on this app. So the same way that when a doctor diagnoses COVID and they need to report it or to notify, the same way that they do for TB, they would also have to report if they make a diagnosis of cancer. So this would help us to get the data. So all that data, those sources, they need to be harmonized. These data, we have like a harmonized database for that. And then we're able to do our trends or to make the extrapolations and to do our reports for population-based cancer registration and for childhood cancer as well as the pathology-based registry. Another example is where we have the South African HIV Cancer Match Study. So this is a virtual cohort of people that are HIV positive and have cancer or have been diagnosed with cancer. It's actually, at the moment, we are sitting with a cohort of HIV positive. And this, I've just put this to show you that we use the linkage to get to this cohort where we had the HIV, the laboratory data, and we got people that we were able to identify by deduplication to have one record per person in terms of who's HIV positive. And then now we also looked at the cancer records. So we're able to put that together. And this is a cohort from 2004 to 2021. And after putting the two together, we had 9.3 million unique people with HIV in the country for that period of time. And of these, over 90,000 had a cancer diagnosis. So we're now able to work. We just finished doing this because initially it was from 2004 to 2014, and then we were updating up to 2021. And we've continued to get it up to 2023 because we just published our 2023 report. So we've seen that utilization, and this is not just unique for South Africa, but we've seen that utilization of diverse data sources to meet the mandate of delivering comprehensive cancer information is very important. And this is what helps us, like for South Africa, to now be able to give to the public what the status quo is in terms of cancer in the country, to the public and also to the state organs, so that they can inform policy. We are able to check in terms of location, like where the greatest need for a particular type of cancer would be in terms of deploying oncologists there or specialists there. Data harmonization is key. It ensures completeness and enabling effective cancer surveillance across specific population groups, because we're also able to study the different population groups and see which population group is actually suffering from which cancer. Advanced techniques like text mining, which we've used before, we've been able to use the HIV data to see, because we know that the HIV program, is very robust from the NGOs that have helped to reach the program up to where it is. We're able to know that we can find records of HIV positive patients. So one of the studies that we did was to see if the cancer diagnosis is made in the place where the HIV, where people are receiving their HIV treatment. And from that, we were able to see that patients unfortunately do travel long distances to get cancer care. So the cancer care is not as decentralized as the HIV care. So that's something that we have picked on. Challenges of digitization, it's connectivity, which people have mentioned. You require electricity and you need internet. You need to build the capacity. People need to know how to use this. Data privacy concerns. Others will think that their data will be distributed everywhere, patient level, but we're very careful where that is concerned. It's de-identifiable data and it's aggregated data that is actually shared. Then you need the setup and the maintenance. But despite all this, digitization ensures efficiency. The patient care is not interrupted because there's lost file or whatever it is. When patients go to a facility and now they have to start looking for the file, that's not good. Then the decision making, as I've mentioned, it's actually data driven, which is good. And the patient history immediately is accessible. And this ensures good quality care for the patient. These are some of the references that I used. And that's our family at the National Cancer Registry in South Africa. Thank you for having me.
Thank you so much, Judith. Excellent presentation. And again, a job well done in South Africa. I hope that everyone else has learned from here. Personally, I like the idea of empowering patients so that they can report their own details. So the living with cancer example is very interesting to me. But I want others to also ask questions. So we have a few minutes left. So please raise your hand and ask a question to the presenters. Anyone wants to ask a question before I conclude? If not, I'll be putting in a question as I wait for you. You can, of course, type it in the chat as well. One thing that I wanted to ask from you, Judith, is you mentioned about these outcomes. So it looks to me that the cancer registration process is like a cross-sectional. We know when you have the cancer and we know that stage and everything, and then we stop there. But you also mentioned the need for example, mortality and linking to that. And now with patients, there's also other things, recurrences, for example. So you need to sort of follow up a person over time to see if they have a recurrence of the disease. And also you have other patient-reported outcomes. How are they doing? How even symptoms, for example. Can you say something about that? I've just seen a paper from study where they were trying to do this long-term follow-up. Can you paint a picture for this? Is it part of the registration process that you do? If not, why? Carry on.
Thank you. Thank you for that question. What you've said is actually a very important aspect of cancer registration. Yes, we do need to have survivorship. So when you speak about cancer registration, yes, it's the incidence and it's the survivorship versus mortality, etc. So for us as South African Cancer Registry, unfortunately, our mortality data is not part of what we have. But we are in talks with the death registry people, Statistics South Africa, so that we can do the linkage. We've made attempts previously. It's an ongoing process. It's not that it's a no, but it's because the death data is kept elsewhere and the incidence data is with us. But having a population-based cancer registry is one way that you can ensure continuity of the information for a particular patient, because there's a follow-up. So, and the other advantage of having a population-based cancer registry is that you also have risk factor data. When the patient comes to the facility, they fill in that form and there's extra information as opposed to what we have in terms of the pathology registry. So when I say that linking the data with Statistics South Africa, at the moment, it was the pathology registry that we were trying to link to the death registry and hopefully to link to the clinical data, but the clinical data is behind. Our population-based registry, which is more central now, was only started in 2017, but it would be nice, say, for Eastern Cape. It would be nice because it's been there longer, Eastern Cape Cancer Registry. It's been there since 1995. And then we have the pathology, which we can still try to link, and then we can link with Statistics South Africa. In terms of follow-up, we don't have like to know whether the patient has a recurrence, but from our data, we are able to link through linkage. We're able to tell if it's the same person through probabilistic linkage. We're able to tell if a patient has had a second episode as long as it was reported. If it wasn't reported, we won't be able to tell. And one of the studies that we're actually planning is to check on recurrence of some of the cancers. Thank you.
Thank you so much. This is all very interesting. I see a question from Kashana Hector, who is asking about funding. How much money is really needed to digitalize registries or set up registries, and how do you get that money?
A lot of money. You need a lot of money. How do you get, the best is actually to have the buy-in of the government. And as you do that, then you do the costing. So you would need to look at different things. The fact that we're trying to move digital, and for our population-based cancer registry, we actually do not collect on paper. They have tablets. So the red cap is installed, it's installed on their tablets. So you need to think around that cost, the cost of, that's as an example, the cost of having the connectivity and purchasing the gadgets, having the connectivity. Yes, they need to be stationed at different sites. Luckily, just like Zimbabwe, we have our surveillance officers at public health sector facilities. So we're not paying rent. But being able to, you should be mobile. If you are the manager, you should be able to go to the different sites. So one of the things that we also factored in was to have a car. I know that might seem like a luxury, but it also just helps to see what's on the ground. But one is fine. For us, we're talking more than 5 sites and then one car. That's fine because everything is digital now, but there are certain times that we need to go. We still have a few places here and there where, from the private sector, where we might need to actually just go and get the data.
Yeah.
So that is what is needed. In terms of the costing, yes, human resource is the most expensive. So you need to have warm body to do the active surveillance.
Indeed. I wonder if the idea of having patients do this, so you democratize it, maybe that will help. There's 2 hands raised, and I think, Anne, you are one of the people involved in this registration process, so I would allow you to speak. We're running out of time, so be quick so that we don't keep people longer than we should. So there's Anne and there's Francis. Anne, unmute and speak.
Okay, thank you. Thank you so much for the opportunity. Good evening, everyone. Mine is not really a question, but just to congratulate the presenters, my colleagues, Eric Chokunonga, and our presenter who has just presented right now from South Africa. Amazing work that you guys are doing. I think I want to make a point about the resources to cancer registration. A number of times we hear these words in various meetings, conferences that you attend, that there is no data in Africa. But the challenge has always been that our governments are not putting in the budgets that are needed to produce this data. So we are really quick to criticize that there is bad data, poor data in Africa. But what are we doing to ensure we have good data in our region? So I want to speak to the leaders who are here, the stakeholders, institutions that are here, to really be our ambassadors so that we find solutions as opposed to always criticizing. We need solutions, we need support. I mentioned that it's teamwork. For us to have good registry data, it requires team effort. It's multidisciplinary, it's multi-institutional. We need all the leaders to really support the work of cancer registry so that we have high quality data that can inform research, that can inform cancer control. So I'm very, very grateful to the presenters today. They have really dwelled the challenges that we face in the registry, in cancer registration, and also propose solutions like digitization and all that. But all this requires resources. So I want to call upon our ministries of health and all the leaders to really support cancer registration in sub-Saharan Africa. Thank you so much.
Couldn't agree more with you, Anne. Thank you so much. Last person is Francis, and then Nancy will come and conclude. Francis.
Thank you very much, Dr. John Black and the presenters. My name is Francis. I'm the cancer registrar at Uganda Cancer Institute, and I coordinate the National Cancer Registry Program of Uganda. I liked the presentation by Judith. I really liked the use of RedCap because it is a web-based digital health tool. So my question or my concern is on the patient's reporting. Are they also using the same tool like RedCap? If so, what are some of the minimum variables that you have included as far as their reporting and the aggregation of their data is concerned? The second thing is on the use of RedCap in collecting data countrywide. How are you ensuring the data quality in terms of IAC check tools, IAC check programs, and then linking it to CanReg, because these are two different tools. So how are you merging the quality and then the data consistency in these two systems? Thank you.
Thank you, Francis, for the two questions. I'll start with the last one, where you're asking about the use of RedCap. So when we formed, or when we did the questionnaire on RedCap, we actually mirrored the CanReg 5. So it's exactly the same, and it's been working fine. It's also in line with the IAC tools. So we always make sure if CanReg is updated in terms of any additional variable, we make sure that the RedCap is also updated. We used the CanReg 5 to do that. Then the Living with Cancer, the patient-led registry, because this was only launched last year, so it's fairly new, and it was the NGO that was already doing this, and then they wanted to have an MOU with us. They already had certain variables that they've been collecting, and what we've done is we've given them our form, the form that is used in the facilities for the population-based cancer registry. That's what they follow. So it is in line with our population-based cancer registry information that we need. So we are collecting what we need to collect, even through the patient-led registry. Thank you.
Thank you. There is a lot of questions. I still have some questions, but we have run out of time, and I see that people have stayed long. Thank you so much for sticking around. Nancy, are you there to give us some closing remarks? And while we wait for Nancy, my last question is, people doing lots of studies and they collect data, can they give it to the registry? Is it usable? Is it useful? And then I'll stop.
Okay, so you mean like if we've done studies and this is what we've found?
No, I'm asking if someone is doing some study on cervical cancer screening or patients with this cancer, and
yes,
and they give you that data. Can that be put into the registry?
Yes, it can, provided we sort of like enter an MOU. We are assuming that they have collected patient level data. So they can give us that data and we can check against what we have collected already. So, and it can fill in the gaps, because currently there's a hematology registry somewhere in Western Cape. They have partnered with us and we've signed an MOU so that we can actually fill up the gaps in our pathology-based registry. Yeah. Because we know that some of the hematological are clinically diagnosed.
Yeah, because many people get research grants, but as you said, we're struggling to get grants for registries, but people are doing lots of research and they are collecting patient-level data as research participants. Okay, Nancy, are you there to close, or someone from Kenco?
Thank you, John Black. Yes, I'm around. So